Hello, everybody. Thank you for joining. We'll wait a few minutes. Start just a little bit after 8. And thanks for coming.
Hi, Maxim. How are you?
Good morning, Frederick. How you doing?
Fine, fine. And you? Good?
All good here. Thank you for joining. Got a busy program, but maybe we'll wait a second. Maybe a minute or more before we start.
Max,
Yes.
there is a noise on the background.
One second. I don't hear it.
Is everybody muted?
Looks like it.
Then it's probably from you.
Hey, can you hear me?
Hey, yes.
Hey, good morning.
Morning. Good morning. Lucas, thanks for joining. Let's just wait a second.
Glad to do it.
Right. So, morning or good day, good evening, everyone. Thanks for joining. The program today is on spine mostly, but not all spine.
Max, the audio is not good.
How about now?
That's good.
All right, thank you. So it's mostly spine today, but it's not all spine. We're going to go a little bit different. We'll start off by this from Lucas and Omar, and then we can then we'll go into the presentation a little bit later for some logistic reasons, but also it's a little bit of a twist. I think it gives like an introduction into what we're talking about. So without further ado, Lucas, thank you so much for showing your stuff. Go ahead.
Glad to be back with the bananas. Here, let me share my screen. Can you guys hear me okay? So I have two cases to share. And this is the first one. So showing you a foot, which has not a whole lot to do with neuro, but this is a 16-year-old who actually presented with an abdominal problem. This was her obvious other problem at the time with chronic leg swelling. She'd had that for years. And a normal neurologic exam. With her abdominal pain in the hospital, she had some imaging. Okay, so here's her relevant neurologic imaging. She had abdominal imaging, which began to show this problem. I think you can see in the thoracic and lumbar spine, there's abnormal flow voids on these T2 images. Cord itself looks pretty healthy. And the lesion, at least what we can see here, extends to the level of the conus. This is how they actually found her problem. They did a CT abdomen pelvis because of her abdominal pain. It turned out to really be a nothing diagnosis, just abdominal pain. And the reason I have the markers here will become relevant in a second, but you can see behind the vertebral body, kind of adjacent to the spinal cord, some mass lesion or that's contrast enhancing. So for her leg problem, which turned out to be a venous malformation, she was followed in our vascular anomalies clinic by myself and one of the peripheral interventionalists. And that was her major problem, was at least when we met her, that her leg was swollen, painful, and you saw the venous stasis changes. So that was actually addressed first, and we were following her problem, her spinal cord AVM. And I guess I would stop there and ask the group, you know, is that what they would do? Would they not treat the spinal cord AVM because she's asymptomatic?
Any comments? Should we get a poll going? A quick poll? Do I have that? I don't know if I can do that.
Or maybe do angiography to better define the lesion.
Was her leg enlarged at all? The left
It
one?
was. The leg was, there was a limb discrepancy. The left leg was diffusely swollen, and you saw those venous stasis changes.
What's breed? So what are you leading up to?
Just thinking about the overall diagnosis of like a Parks-Weber Klippel-Trenaunay syndrome.
Yes. What do you think?
Yeah, so I agree. I think she has, to me, those are two distinct diagnoses. I think
Yes.
she has Parks-Weber. That was the unifying diagnosis I gave her. You know, these kinds of things people like to argue about a lot, but I like to at least assign a name if I can to the problem. And so that's what I thought it was.
Excellent. Good. So, and that underscores, I mean, obviously here the peripheral problem was the obvious one, but whenever someone has something like that in the spine, I think we should all be doing like a good complete neurologic exam, including a skin exam, right? To see what else might be out there. Seem to have lost. I can't do the poll, so
Okay. So
yeah, I can. No, I can do this. All right, fine. So I mean, most people, I guess, would argue for diagnostic angio here. I don't think there's going to be a lot of disagreement here, but you do a diagnostic angio. Let's say the angio shows what it shows. Patient's asymptomatic. A is treat, B not treat.
Or C, angio and decide.
Okay, so let's say we did an angio. So yeah, I mean, in the interest of time, we're going to do an angio, I'm sure. But if there's an asymptomatic spinal AVM, so treatment seems to be like leading for now.
So A is treat.
A is treat, B is not treat, and C, I guess people are voting for an angio, but I think there's going to be angio first, I guess. But in order to treat, you need an angio.
Well, doesn't look like much consensus to me. So
That's the result. So anyway, let's see how it goes.
So what I thought was interesting in this picture is you can see in the left neural foramen that T2 hypointense lesion, which we saw in the CT. It's hard to compare apples and oranges whether it's really bigger or not. This is actually quite a while later because we were dealing with her leg, which was really bothering her, the peripheral vascular problem, the venous malformation. Max, can you move the poll? All right, I got it. So sorry. This slide is kind of screwed up. Sorry. What's appearing behind it is supposed to show you the difference between 2015 and 2017 in that lesion, or that portion of the lesion in the neural foramen, which has increased in size significantly. So we actually followed her for a period of time, mostly because her leg was so problematic. And I had a hunch that this was going to be a bad lesion, but when it came to angiography, this is what it looked like. It'll play through another time, and then it should stop so we can all comment on it. I'll leave that there. That about there. And anatomically, I thought this was an interesting case. You can see from below the radiculopial artery is really an extension of the lateral sacral artery. The middle pane shows that kind of magnified more and centered on the AVM itself. And then you can see a very large radiculomedullary artery in the first pane. So like most of these large AVMs, it's kind of a jigsaw puzzle to put together the full extent of the nidus, but it's large. And based on the MRI with this, it's not really intramedullary, it's at the level of the conus. But what really got my attention and why she had the angiogram was this growing aneurysm of the radiculopial artery, which I guess one of the questions I had, I was never sure 100% whether this was at on the surface of the dura or below the dura, really. It's right there at the junction, and whether that merited treatment or not. was one of the questions that came up in our cerebrovascular conference. What should be treated first, the AVM, nidus itself, or that growing aneurysm? So I guess that's the last question before I show you what we did, because we did do something.
Any comments? Anyone want to speak up? I guess, Mike, one question is like, where is it located in terms of the levels? I assume that we have the image on the right, correct, is the image from a, say, like you're in the iliac, and so that's the aneurysm that we're talking about.
Yep.
And then there's a couple of other ones, right? So that would be somewhere in the lumbar region, right? Below the cord.
Correct. Yeah. So the panel on all the way on the right where you see the lateral sacral, that's the same injection as the middle panel, just centered higher. And then, so this is showing all the major spinal artery supply, these three pictures. Really, they're two different pedicles.
No, I mean, you mentioned radiculopele for at least the one on the right, correct?
Yes.
Yeah. I guess it's a question of like where the cord ends and what you call them at that point. And ultimately the question is, what are they supplying, right? Like all these things. I mean, some of these are going to be on, like the one on the right is likely on a nerve root, correct? Like the S1 nerve root or something.
Do you think that has a risk of subarachnoid hemorrhage? I guess, do you think it's below the dura?
I'm not sure. What do we think? We think that aneurysm is intradural? Yeah, anyone? My guess is yes, but I think it's
So
it's okay. I guess it's intradural, and the other question is, again, what's the rest of the supply to the cord? I assume there's some kind of anterior spinal or higher up. But
well, I think your pain to the left is your anterior spinal. It just,
that would be at some, yeah, that looks like
yeah.
mid-lumbar level maybe, or?
Yeah, if I remember correctly, it's at L2, but it's been a while. But yeah, so I felt like I didn't show all the spinal angiogram. We did a complete one, but this really defines the spinal cord supply from above and below. And that's why these pictures are shown. And I guess that's something important to say. If we're, and I think most people know that if you're doing a spine embolization or embolization of the spinal cord, or a lesion proximate to the spinal cord, I always try to define that, the cord supply above and below. So that's why these pictures are shown. At least what we can see, as you know, with high flow lesions, sometimes some of the spinal cord supply can be obscured because the high flow portions kind of wash out everything else. It don't allow everything else to be visualized until these go away. So our debate was embolize the AVM proper or embolize the aneurysm, or I guess you could do both if you're really aggressive. In the interest of time, I'll show you kind of what we did. I was really worried about this aneurysm. I wasn't sure whether it was actually intradural or extradural, but it worried us enough to try to occlude it. Now, it's a very dysplastic vessel. You can see at the level of the aneurysm. And certainly technically it would be easier to occlude the artery itself and just do kind of a vessel sacrifice at that level. We went back and forth about that. My concern with that is then you're truly changing the hemodynamics of the AVM itself and pushing all the supply through the anterior spinal. And maybe that doesn't do anything bad, but potentially changing the hemodynamics could result in a rupture. I mean, certainly it could rupture or cause myelopathy without altering those hemodynamics. But we basically did this treatment where we coiled off a majority of the aneurysm. We were never able, it was really circumferentially sick, the vessel. We're never able to get coiled to go all the way into that little teat. But I think should be a run. I thought I had a run, sorry, but there's quite a bit of stasis at the end of the treatment. And then you can see a follow-up. Those last two panes are a follow-up picture about 6 months afterwards, demonstrating at least some degree of stability in terms of the occlusion. It's not growing anymore. So I think that's the last slide for this presentation. Let me see. Oh no, sorry. So, and when we did that, I thought about potentially treating the AVM nidus itself. My feeling is the natural history of these lesions are really bad, but the treatment risk I thought is really high as well. And we endeavored on treating this from this posterior spinal artery essentially. And the pains in the center, so passing the aneurysm with a microcatheter, and the pains in the center show you run from below from that lateral sacral, and then pain all the way to the right is a microcatheter injection, but I could never get a stable microcatheter position, nor was I confident that I was imaging the AVM sufficiently. And I think a lot of that had to do from washout from the anterior spinal from above. There's one very long continuous lesion. So essentially I just left it alone and have left her alone in terms of the spinal cord AVM component. And, it's a tough lesion, and I'm still worried that she will have symptoms, but I haven't planned to treat her again. We've just been kind of following. So be curious other people's thoughts, how they might tackle the nidus, and if they would at this point.
Yes, thank you. Any comments? Keisuke Kirifon. I see there's some. Can you elaborate for the group for this Zoom chat?
Okay, I don't know how to pronounce this. There was a comment from Keisuke. He was asking about the name of this artery, because this one arises from the lateral sacral to the feet part of the conus. So it's not very common to see this kind of feeder to an AVM in this area. So he gave it a name. Anybody knows how to pronounce this name? I don't know.
It's a French name. It's Desproges-Gautron.
Okay, so that's it. Thank you. Okay, so it's a description of this lateral sacral artery branch going to supply the area of the conus. But concerning this, I don't know if the patient is asymptomatic concerning the conus lesion. I don't know if you embolize from this branch, it would do any good to the patient in the future. I would be reluctant to do anything more aggressive than treating the aneurysm you just treated.
Well,
and are you sure the lesion in the leg is it doesn't have any like shunt-like appearance, only venous?
It's only venous. My partner, who's a peripheral interventionalist, did do an angiogram on her, but typically we don't do angios on things that look typical venous. In addition, and she has a ton of imaging, but we do tricks MRI as part of our vascular protocols in our vascular anomalies clinic. So both the tricks, the clinical appearance, and he did do a peripheral angiogram. There's no shunting. It's a truly venous low flow lesion.
Okay. Because I was wondering if we can call this one a spinal metameric syndrome. seems like
Yeah.
a strange lesion. Yeah.
Yeah, I mean, to me, the way I've always understood those should be at the same level. And so if there was and they should be, as you said, they should be shunting lesions. So there should be dura, bone, muscle, skin involvement, or at least partial involvement at the same level where the AVM is noted. So I don't think it's metameric. I think it's Parks-Weber syndrome. But I think your point's important. You have to figure out whether it's a shunting lesion or not, however you decide to do that. And then she had a pretty thorough exam.
Okay. So, anyone else? Just in general, I would say that as a community, as a neurointerventional community, would it be fair to say that in terms of something as complex as this, which is like, we can call it a conus AVM, or it's a quad equina AVM, phylum terminale lesion, whatever you want to call these, given the asymptomatic state, I think there is pretty good consensus that an embolization, a prophylactic embolization in a sense, is not something that most people would entertain. So a lot of it is just basically focusing on symptom management, right? If there's a hemorrhage, we try to find what bled and just attack that. If there is a concerning feature like this aneurysm, for my part, I totally agree with what was done. Like, you want to take care of what you think is a problem without changing as little of anything as you can otherwise. Anyone else have any other comments? Any role for radiation of any sort or any other treatment modality? In terms of the anatomy, I guess what I would say is like that artery, right? The artery, that's the S1. I assume that's the S1 radicular artery. That was at the S1 foramen.
Yep.
I think that I don't know if it's not really so well studied perhaps, but like every nerve root, every nerve will of course have an artery on it and a vein. And so that radicular, you want to call it radicular artery, they can enlarge if there's any demand. So I think one way to think of this is just a radicular artery that's supplying some kind of shunt, whether it's demand or flow. But my guess is like embolizing this vessel would endanger whatever artery it's sitting on, which of course you wouldn't do, but just for anatomy sake.
So, Max, I have one other case if you want to go through that, or start the usual. It's kind of a companion case.
Well, let's do the case.
Okay. So this is a 16-year-old was referred with leg atrophy, a very abnormal MRI that you can see in the thoracic level with T2 signal change. And he has already been sick for about 2 years by the time I saw him. And he's got myelopathy. So a very different situation than the last child. And this is his spinal angiogram. And I put in the bone for reference. Sometimes I like to do that just to show where it lies within the cord. And is it truly midline or not? I do spinal angiography under anesthesia, so usually you can get patients nice and straight. They don't move a whole lot. And you can see this, what really looks like kind of diffuse nidus. It's not compact, at least not the way I would describe a compact nidus. I like the lateral picture because you can see the posterior spinal and anterior spinal artery and how they kind of interact with each other, with some of the communications along the PL surface of the cord. I don't have the left T9 injection, but there's a posterior spinal from the left T9, which is right here, radicular PL artery. So he was symptomatic. So we did feel like he needed treatment. Didn't in our cerebrovascular conference, it didn't seem like there was a surgical option. I just wasn't sure whether I would be able to treat him or not, given the diffuse nature of the nidus. So I studied it a little more carefully to really understand whether this was treatable or not. We advance a microcatheter into the anterior spinal. That's the middle frame here. And right before kind of that hairpin turn, you start to see some of the arteries of the spinal cord proper that are feeding the AVM. And it is a diffuse nidus to me. We thought that with this case, if we could get to this point here and truly be in what I guess I would consider a intranidal position, that would really be the only safe way to perform an embolization. The posterior spinal is too small. I didn't think I could get into it. Of course, that would be preferred. And one of the questions I had for the group is in terms of neuro monitoring for these cases and provocative testing. I saw a multitude of approaches in my training, and talked to people. They use different approaches for both of those things. Would you use monitoring? Would you do provocative testing? And I guess how much stock would you put in those two modalities?
All right, any comments?
So probably to start with, you probably need to know what the actual cause of the patient's symptom. You know, the patient has myelopathy, but is it venous congestion? Is it compression? Is it like arterial steal? It wasn't probably a bleed, right?
No, he didn't bleed, I guess.
Yeah. So there's no certain point that you need to go and just mark as a target to embolize because there's no bleeding point. So probably, I don't know, maybe it's some kind of like venous congestion because you see a lot of dilated vessels around the area. And so we try to, it would be nice if we can reduce the flow. But from this microinjection, so it's not the sulcal commissural arteries that are feeding the lesion, but it's rather a PL branch of this radiculomedullary artery, because it's before the hairpin curve. I don't know. How do we interpret this thing? It will.
That's a great point. Can you elaborate a little bit? So what the sulcal commissural arteries are and
Me? Okay. Okay, this sulcal commissural, usually we can see it arising from the posterior portion of the anterior spinal artery itself at the midline. And usually at this area, we don't see those perforating arteries. Rather, we see the PL branches arising from this radiculomedullary artery before it reaches the hairpin curve. So they're not the true perforators, but they will perforate at some point. But anyway.
The implication is that they're sitting closer to the surface of the cord.
Yeah, and it's probably a little bit more comfortable to embolize if you can find a good branch.
There was an earlier comment about doing thin section MRI for the previous case, which I'm not sure in the previous case it would be so helpful because I think we're below the cord. But here, is there a role for some like advanced cross-sectional imaging? Do we think, like to better define where? Here we can kind of see most of the vessels seem to be ventral, but like more and more people are doing these like space T2s, whatever, like some high-res stuff.
Yeah, I mean, again, I didn't show all the non-angiographic imaging, but it was, at least to our team, pretty apparent that this was within the cord. To me, and I don't know how well this projects, but even that sagittal image looks like there's flow voids inside of the cord. And I think that was very different than the last lesion where most of it was on the surface of the cord. But obviously the conus location has its own complications with the anastomosis between the anterior spinal and posterior spinal right at the level of the conus. But I thought this was intramedullary. Our team thought it was intramedullary. And so I wasn't sure, Kitty Pong, 100% whether these were sulcal commissural arteries or whether they were peel on the surface of the cord. I guess my feeling in terms of safety of embolization would be a truly intranidal position to some extent makes those two situations as equivalent as possible in terms of safety. It's still a high risk embolization requiring precision. And yeah, and my interpretation of the angiogram, I didn't give you guys a video on this one, was for the size and extent of the lesion, there wasn't enough venous outflow. And the way I understand myelopathy, his clinical condition is generally that. It's a venous outflow problem relative to the arterial flow going into the lesion. So I thought he had a symptomatic myelopathy, and I agreed, or that was our rationale for treatment, was that we needed to balance the inflow to outflow problem.
So you and Kitty Pong have the same interpretation.
I think so. He was more nuanced in terms of, and maybe I'll ask him to repeat himself, but talking about venous congestion, and I guess you also posited some other potential pathophysiologic problems, but I think they all lead to myelopathy, right?
I mean, I would agree with both of you. I mean, seeing what I see, the few images that you have, I have the same feeling. For the amount of nidus that you have, there should be a lot more veins.
Yeah.
And I believe, and it's just a belief, that the way these people come into trouble is that they have, just like a brain AVM, they have some principal vein that develops to like serve the shunt. Over time, that vein becomes occluded for whatever reason, and then you have a venous congestion issue, just like brain AVMs might, right?
Yeah. Or an acute hemorrhage because of the same.
If they survive the pressure, whatever, if the process of occlusion is survivable, right? If they don't bleed, they can get into this venous congestion problem. And in that sense, they kind of like, it's not a dural fistula, but the pathophysiology starts to kind of, sometimes sometimes it's almost on that spectrum.
Yeah.
Although here you have obviously more of an intramedullary nidus.
Yeah.
But yeah.
So I didn't use a WADA test or monitoring, and mostly because I saw a lot of that in training, and essentially the decision always came down to an anatomic decision, no matter what the monitoring demonstrated or the WADA resulted in. You could inject lidocaine and sodium amytal and lose potentials. And if the decision was that we're in a safe anatomic position, usually or almost universally embolization would proceed. So I didn't add the complexity of those things. We were able to get the microcatheter to this position here, which I thought was intramedullary, or sorry, yeah, within the nidus of the AVM proper. I don't know how well this is going to project. It's not that important, but it's too dark. But it's the glue injection itself, using about 25% MBCA with tantalum, and everything you're just watching that reflux and making sure nothing comes back retrograde along the path of the catheter towards the anterior spinal. Really nothing. Everything has to go forward. And there the microcatheter is removed. So he went through.
That's real time. That's pretty
That's
much.
real. That was real time. Yeah. So he went through 2 stages of embolization, and you can see pre-embolization, post-embolization, that this whole area here has been occluded, and you remain with continuity of the anterior spinal. You can see the ascending limb. And then you can see it here too. This is pre-embo 2, and there's a microcatheter injection, again, truly intranidal. And this is the final post-embolization result. I don't think it's cured, but it was significantly reduced in terms of its vascularity and appearance of the veins. His myelopathy was pretty advanced by the time I met him, but he was still able to ambulate with assistance. And so we've gotten him to this point, which, you know, this is where we kind of left things. And I like this picture again because you can inject from T9 on the right and see the posterior spinal on the left. And so showing you those connections that we can see around the surface of the cord, the peel connections. So I like these cases to compare them because the presentation, asymptomatic versus symptomatic, the anatomy is comparable, but importantly different in terms of the location and type of nidus, and treatment approach. Like I think most spinal lesions, truly intramedullary, perimedullary lesions, needs to be tailored to the clinical situation, not just the angiographic images of the patient. So these cases are few and far between. I think both these kids have been treated several years ago. So it's not like I have a huge experience with these. So we try to go rationally and slowly. So I'll just leave it at that.
Max, there were a couple of comments from Sudhakar. He was, when he said thin section, probably it was about the other case, probably meant like trying to define where was that aneurysm, if we can use thin section MRI. And I think that's what he meant. But more about this case, he's saying, is there any role of radiation prior to Embo? I guess that's what he meant by STR.
Right. Anyone want to elaborate?
I've never seen it used for a true spinal cord peel or intramedullary lesion. I'm curious the rest of the group's experience with that.
Hello, can you guys hear me?
Yes, please.
Tibor here. Yeah, so I had one patient who was treated by somebody else. She came from Malaysia, and she was a young lady who had a true spinal cord, thoracic spinal cord AVM. It was a peel AVM, and she had, I forgot the symptoms, whatever. I don't think she bled, but she was symptomatic, and she got treated with stereotactic radiosurgery and nothing else. And I was quite skeptical about that. When I saw her, she was like, I don't know, 2 or 3 years after treatment, and they moved to the US, and they needed a follow-up because she was trying to get pregnant. And so I did a follow-up angiogram, and there was absolutely no trace of the AVM. So that's my total experience about spinal cord AVMs treated by radiation.
Does anybody know of a center in the US treating spinal cord AVMs with radiation?
Well, I mean, at NYU there was 1 or 2, a couple of cases while I was there that were high cervical spine, ruptured cord AVMs in like there was a 12 or 13-year-old girl who got treated with stereotactic radiation, and I don't know. Eventually, I don't know how she did long term because I left, but yeah, we had one case.
So case report, see more comments, right? Radiation for spinal limb, just case reports. I followed up on your patient, Tibor, one more time. It was like several years after.
She went to med school, right?
I think she moved. I might be.
Oh, okay.
A unique case. So I don't, but she was very stable. I just did another MRI, but at that time because you had done a follow-up angiogram, and I think it's CyberKnife is what was used.
It was CyberKnife. Oh, you're talking about the Malaysian woman?
Yeah.
Okay, yeah.
There's a series of that. She had some sensory symptoms, and she mostly recovered. She has some paresthesia still, but last I heard it was years ago. But I think at least there's one series on that. I don't know of a center in the U.S. that does that.
Stanford, they do it at Stanford. That's the only place that I'm aware of.
Stanford?
Yeah. The name of the guy is Steve Chang. That's the only guy that I'm aware of.
Thanks, Aris. Yeah, the ones we've done were like basically just high cervical ones, so you could put a head frame on and still target them like you would, you know, a brain lesion.
To me, the interesting thing about that case was because she presented quadriplegic, the 14-year-old girl or 13-year-old girl at the time, she presented quadriplegic. She required intubation and tracheostomy, so she was completely trashed from the hemorrhage. And I was kind of young attending, and Dr. Nelson was out of town in Europe or something, and so I did a detailed angiogram, and I remember vividly thinking that having the strong urge to embolize the thing, because you know I saw how you could get to it from the lateral medullary artery and potentially glue it and this and that and the other thing. So we spoke with Dr. Nelson over the phone, and he just said, you know what, she's gonna recover from this event, and you know, if you go in there and mess things up, you know, you make her deficit permanent. And I was a little bit skeptical about what kind of recovery she's going to make. And, you know, she essentially, over 6 months, she went back to almost normal. So for me, the lesson in that was that, you know, it feels like when somebody's at the maximum point of their deficit, it feels, as a young person, it feels really difficult to stay away from doing something, because you feel like, well, I could do something, but am I not doing it because I'm so inexperienced and I fear, you know, pushing myself. And so there's a balance where you know, you need to realize that you shouldn't be doing something just because you have these questions in your mind, and because, you know, the patient happens to be temporarily trashed, and you shouldn't use that as an opportunity to experiment. That was my takeaway from that particular case.
So the provocative question would be, what would you do in Lucas's case?
The Durham County Court.
This case here.
This one or the first one, Max?
This one.
This one?
Oh, both, I guess. I mean, the first one I think is a very safe kind of thing that was done. I think most of us would agree. But here, you're in there. The deficit. I mean, if the deficits are progressive, it's one thing, but I don't.
The summary is he's myelopathic. but can still walk at the time of decision to treat or not treat.
I think I would agree with you, Lucas. I would treat this, and it's a great result. I really don't know risk to quote these people. Like, we just pick a number. I would probably pick a high number, whatever that means, 20, 30%. But
I guess
technically it was really like awesomely done.
To give you a sense, what I say is usually in a lesion where I don't know what the risk is. I just say there's a good chance I won't do anything at all because I may not feel it's safe. And then, yeah, I think that's one important statement to make going in. So there's not this feeling of, well, you were there, why didn't you do something? That may be the outcome. And there are other cases like the first case where when I got to a point where I was in the spinal cord AVM, I just backed out. I didn't know what I was looking at essentially, and I didn't have an avenue to do it safely. So I think that's always important for these kinds of rare high-risk lesions. And then, yeah, super high risk. I don't try to assign a number because I don't think I can be accurate.
Thank you. Any other comments? Anyone?
Thanks for having me back, Max.
Lucas, thank you so much. Thanks. All right. So, Omar, are you around?
I am.
Okay, Omar. We'll take a break with a non-spine case, and then we'll do the lecture after this.
All right. Can you hear me fine?
Yes. Thank you.
All right. Let me see. Sorry, I'm just trying to share my screen here. 1 second. Here you go. Can you see my screen, Max?
Yep.
All right, thanks a lot for having me. I'm presenting this on behalf of myself and Dr. Busky, my partner, who graciously assisted me with this. So I don't know how much the group has an experience with a Commissural device, which is I think I would say a stent that is used to assist with wide neck aneurysms. We started using this recently here, and we were pleasantly surprised with the way it acts within the artery. So this is a 4-year-old who presented with subarachnoid hemorrhage here, as you see on this CAT scan. And an angiogram showed that she had 2 aneurysms, 1 ipsilateral in the left PCOM proper, as you see here. She had a hyperplastic left P1. And she also had a contralateral ophthalmic aneurysm, as you see as well. So we went ahead and just coiled the aneurysm in the acute phase. Went well. She was discharged at normal baseline neurological exam. And we followed her later with, I believe, 3 months angiogram, which was stable. So since she was ruptured, she had little risk factors. At that point, we decided to bring her back and treat the other side, which we decided to do a pipeline. This is the before and after. Pipeline worked really nicely for the ophthalmic aneurysm on the other side. I don't exactly recall the sequence of events that happened, whether we checked on that left PCOM one more time at the beginning or on the way out, but it was an unpleasant surprise. And part of this is probably due to COVID, because we were supposed to get to this very quickly. And then because of COVID, it was months before we got to do the pipeline. You can see there's recanalization at the base of the aneurysm was almost like a second aneurysm at this time with like a really wide neck. And I'm sure surgical option is a possibility here, but we're now stuck with a pipeline and previously ruptured unprotected aneurysm, as you see. So we decided to go with the Commissural stent-assisted coiling to treat this and potentially buy some time as well. So Commissural is not detachable. It goes on a wire, and it accentuates with a wheelie that's easy to control. And it comes in 3 sizes, I believe the 17 and the petite and the 21. So this can go through a 17 catheter, which is a nice feature. It's you don't need bulky catheters for this. So here you see there's an SL10 in the cavity of the aneurysm with a couple of loops in place, and then the device is deployed from the posterior communicating artery into the carotid. I usually don't do this with a balloon because of the difference in the diameter between the internal carotid and the PCOM. So here, I mean, this is where we're really surprised by how this device acted, because you can see with a little bit of accentuation, it really married the whole junction of the PCOM and internal carotid and the neck of the aneurysm, and provided very stable structure during coiling. You can collapse the device. You can collapse the device and accentuate it as needed during the case. The advantage is that you don't create flow arrest during the coiling. People who've used this more than I have, and I'm sure maybe somebody in the group can comment, use aspirin Plavix during this in case, failure and you need to put a stent. And because a lot of metal can cause thrombosis at some point inside the stent. So here, the patient is aspirin Plavix, as I mentioned, because of the pipeline on the other side, and she was fully heparinized as well. We had a nice basket at the end that we filled it. But here you see the silhouette of the stent and how it's really covering the junction of the PCOM carotid artery and the neck of the aneurysm. And this was her final result, which was satisfactory for the time being. We don't have follow-up on this since then yet. This is recent. And that's pretty much it.
Thank you. Omar, thanks.
Thanks.
So I'm sure there are people familiar with the device here. Any comments, anything? Suggestions? I mean, we've used it as well. We're happy. We're happy with the device. They're different sizes and so forth. But like anything, the stuff that we get here is probably been several years available
in Europe. Yeah.
So there's a lot of experience with that over there.
The one thing that I noticed, I don't think if you experienced the same thing, Max, is it really traps the catheter. So what I learned in more recent cases that I need to be very careful, because I think it increased the pressure on the catheter tip, and you can force coils in places under pressure, which is not always a good thing. So I usually now keep track of, am I getting enough brushing back and forth in the tip of the catheter? I'm more careful with catheter precision because it's less likely to have the catheter kick out. It seems that depending on the position, can really trap the catheter. So that's one thing I keep an eye on now.
I agree. It also depends how much you can control, how much you expand it.
Yes, exactly.
The more you expand, the more it can get, it really holds it. Anybody else? Muhammad is asking, can you jail? Do you have to jail? I think you have to jail. I don't think you can go through this.
It's jail. You can't go through it now. And you people don't suggest that you collapse it and decollapse it. You collapse it and accentuate it too much. But if you have any question about like the interaction between the coil loops and the stent, because there are cases where it's rare, it's reported that the coil actually went through the strengths of the stent, and that could be a disaster. But I haven't seen much of that.
But you can, just like with a balloon, you can kind of deflate it and see if the coil mass moves before touching. Yeah,
it's very easy. Yes.
Rudy, you had a comment, right? Using without antiplatelets for ruptured cases.
Yeah, we have used it for ruptured cases, and the problem is you don't get flow arrest in case you get in trouble. So if you rupture, it's not going to protect you. You have to keep on coiling or take it out, put a balloon, so it becomes really complicated. But we've used it successfully with one ruptured case as well. No aspirin, no Pavix, and little heparin towards the middle of the case. We did not have thrombosis with that one case that we did.
Okay.
Well, you can also, now that we have IV cangrelor, you can give the cangrelor, it takes effect in minutes, and then if you do have a rupture, you can stop the cangrelor immediately. And that's one comment. The other comment is, everybody remember Lee Guterman's device, the Gatekeeper? This is essentially exactly that device. It's just 20 years later.
Lee Guterman?
Yeah.
Oh, he trained. He never mentioned that device. That's funny.
Okay, Adam had a comment. What's the trade-off with the balloon? It's on the chat. Like, obviously, as we're saying, the balloon gives you protection from rupture.
Yeah, and I mean, I think with this, yeah, I mean, I don't know if the balloon would act the same way, and in this junction, A and B, you don't get the flow arrest that you get with the balloon, so you're more relaxed when you're working because you're taking your time with the balloon. It's like you're nervous about the flow arrest and you deflate it every single time. With this device, not quite as often.
One trick that you can do, and we've done it with Erez and Max a couple of times, to feel better with yourself, you can bring the Comaneci inside a Scepter C. Use the Scepter C as the catheter in which you bring your Comaneci, so you have your balloon there, and that may make you feel better in case.
That is very smart.
That's very smart.
Absolutely. Yeah, I have to give credit to Amir Hassan, who thought about that first, and we decided that it could be useful.
Also, the new Eclipse balloon is really, really conformable. Even if you put the Eclipse balloon in the carotid, it will herniate into that PCOM, into that fetal origin PCA origin. You could also even probably, it's also highly, highly navigable. You could probably also just put it into that fetal origin PCA as well.
Yeah, I mean, the balloons, I think there's more options in the balloons. So that's another one. The one thing about the Eclipse balloon is it inflates and deflates a lot faster.
Yes.
Than the
Scepter.
Than the Scepter. I think we can argue about the navigability, but in terms of deflation, for sure. All right. So I guess to be continued. We'll see what happens to this PCOM, right?
Absolutely. Yeah.
If it acts up again, you have a little P1. So, right. So that's you got an option there too.
So what are you thinking if it acts up again?
No, you could, if there's a P1 there, right? There's a P1 inside, a small one, so you could pipe it. I'm sure you guys know.
For sure, yeah, of course.
So I'm just for the group. Asking to clarify the use of the Scepter C's backup in case of rupture. Yeah, basically like the Scepter C is your microcatheter. You put the Comaneci through that. The Scepter C ends up like being a little bit more proximal. So depending what kind of aneurysm you're treating, like maybe inflating the balloon where it's going to be, like may or may not help you too much. But like in this case, if the thing ruptures, you can inflate the balloon in the carotid, and maybe you'll have some backflow from the P1 still, but it'll do something. So it's just some belt and suspenders, I guess.
Or if you deflate the Comaneci and you can that advances the microcatheter. I mean, you can advance the microcatheter over that.
And you can use Comaneci as a scaffold, like in a stroke,
right?
Plated, whatever, like all these things.
Yeah. Have you tried it in stroke or in vasospasm, the Comaneci?
We have tried it in vasospasm. We were not too happy. It's I mean, it goes distally, but I think the trade-off is that in order to expand the Comaneci, it has to foreshorten, right? Like a braided thing. So what happens is it probably ends up like scraping the wall a little bit. So what we've seen is kind of, you see like areas where you plasty it and it improves. And there are areas where you plasty it and it seems to like be a little angry at you. So unlike the balloon, which I think is a little like I feel it's a little bit more like predictable what the result might be. Here it's like, I feel like it's a little more, I don't know.
Yeah, but the difference is that you can take it really distal into the distal ACA, distal MCA. We've been in the M2, M3, which we are not usually taking balloons up there. Now maybe with the Eclipse.
Thais, so you also use it in vasospasm, right? Distal, definitely distal is safe, whatever. Like it's for distal.
I guess if we're talking about vasospasm with the Tiger, the relative stent to the Comaneci is more used for that, maybe in Europe.
I mean, there are series, right? Like there are series and use of that in spasm.
I'm not sure that the Tiger is better than the Comaneci for spasm because the struts are a little bit bigger in the Tiger Triever as compared to the Comaneci. I'm not sure that it will make the same results, but we never tried the Tiger for spasm actually. So I'm not sure.
All right. Well, thanks, Max, for having us.
Thank you. No, thank you for the case and discussion. Okay, so now we move on to the presentation, the spinal vascular anatomy presentation. So I'll go ahead through that. I think in many ways, like, depends on the group. The group here, a lot of people here probably will find this more like, there's some cases there that I think would be useful, but there's basic information there as well. So let me go ahead and start that. Can everybody see the screen? It should just be the screen with this slideshow. Again, just to kind of give a broad overview of this, I think a lot of this obviously is not like something you can learn in a little bit of time, and there's a lot of information out there for reading and so forth. But just in general, to give a flavor of this, and a lot of it's built on the stuff that's on the website and also from Armin Thrones and Los Jonius Bernstein and Terboug's books as one of the main sources. We always talk about this. I think everyone's aware of this as a somatotopic organization of the body. And so part of that is reflected in the vasculature. And so the vessels too have these like somatotopic organization, and it leads to a lot of homologies in terms of different segments. So this picture here just illustrates that, how throughout the axis you have these homologous vessels that I think are important to pay attention to. These pictures, again, like it's more just how to approach it. Like if you are, say, like what we kind of like to do, like say you're teaching this to somebody. One way to systematize the teaching of spinal vascular anatomy is to just kind of think of like centripetal and centrifugal organization. For arteries, you can kind of go outside in. Like, okay, from the aorta, you have segmental arteries, and then you can talk about the different anastomoses out, outside of the spinal canal. And then as we move into the dorsal division, or the stuff that goes through the neural foramen, you can talk about the outer layer of vessels, which is mostly like has to do with like epidural space or dural vessels, and then we go inside, and then there's vessels on the surface of the cord, and then finally inside the cord itself. For the veins, it's the opposite. You could start inside and like follow the blood out. So that's one way to like think of it in terms of presentation. Okay, so you've seen these pictures, all these different anastomoses. They all have names. You can look up the names, but essentially there's just a lot of obviously longitudinal anastomoses, transverse anastomoses. The main left to right anastomosis is in the epidural space, so that's the epidural arcades. We'll get to that. And then there are also longitudinal anastomoses inside the canal also. Famous picture, right? So everybody, like, that's the source. One of the sources, surgical neuroangiography. You study this picture, you're gonna know most of what you need to know. The embryology we are all familiar with. It's basically, again, this segmental organization, this early kind of like segmental arrangement, multiple sources of supply at each segment to the developing cord. Over time, kind of developing these longitudinal anastomoses, and then finally leading to something like this, where some of the vessels persist as radicular arteries, basically supplying the nerve root, and then continuing on to also supply the anterior spinal axis, so we call that radiculomedullary. The ones that supply the posterior spinal, we call radiculopial. And again, like, it's only as good as you can see. These vessels, we number them, how many there are radiculomedullary arteries. Well, it depends how good your tools are. And we have good cases to show that in addition to what you see, there are these little vessels. So for example, you see this like little vessel here that might be well below the resolution of your angiographic equipment, but it has the potential to reconstitute the cord, and especially over time, to rearrange the spinal supply. So if, say, there's a dissection of a radiculomedullary artery, you might find, or an aneurysm on it that ruptures and over time that occludes, you might find coming back later on that the spinal cord supply has reorganized, and there's a new radiculomedullary artery here, quote unquote, that you've never seen before. Well, it's not new, it's always there. It's just below the resolution, and it's grown up to do what it needs to do. So anyway, so this is again like this idea, we're looking from the outside in. There's a lot of anastomoses, of course, on the side, anterior, on the side of the vertebral body. And then as we get in, the dorsal division, or whatever you want to call it, the branch that goes through the neural foramen, and that would be a series of these arteries that supply the contents of the spinal canal. Amongst those, the principal ones would be the vessels in the epidural space, or on the surface of the dura, that would be supplying the dural structures, and also participate in the supply to the back of the vertebral body, or some of the posterior elements. And then, of course, you have the radicular arteries. Each nerve has a radicular artery on it, and then some of those are persistent in supplying the cord as radiculomedullary or radiculopial. So just some examples. This is just an injection of a particular level, whatever that is. And you have, in this case, there's an anastomosis, a post-transverse, a posterior spinal network anastomosis here that allows us, that's the principal one. There's another one, the pre-transverse one that's marked as G, that allows us to see the level above. So all of that is very richly collateralized. Just another example, again, here you see actually a characteristic radiculopial artery. It has this like very tight hairpin turn, and usually is located to the side of midline. We'll show that a little bit later. And then here's, you see, again, some anastomosis. This one right here, and then there's another one. This is the epidural arcade going to the right side. Some well-known variants. So here's an L3 conjoined down at the bottom. They tend to be a little bit more often conjoined like that. Here's, we showed this before, there's like some of these interesting variants and they have some implications sometimes. So here's a not an uncommon situation to see one segmental artery supplying two intercostal arteries. And occasionally, like very occasionally, you see something like that on the bottom. So here's a left T10 injection and the T10 rib is right here. And you also see the T9 and the T11 intercostal arteries in this case, supplied by this level. Now, sometimes it's just a curiosity, but if you think about like, what is this vessel here? So this vessel here is this G, is the pre-transverse anastomosis. So, or it has other names too, but essentially that's on the side of the vertebral body. And so that's the supply to that. Now, the importance of that is, so you have something like this, right? Again, that shows the same thing. The interesting thing is, like in this particular person, we needed to find the anterior spinal artery. There's a pre-surgical evaluation. Well, we're looking, and you can't find it. We have this left T4, we have the right L3, but like none of them add up to very much. And so ultimately, where the artery was found is at left T9. And the interesting thing about that, the left T9 is one of the levels. So remember, there was a left T10 segmental injection supplying the left T10 intercostal artery, as well as the left T9 and left T11. Now, just because it supplies the left T9 intercostal artery doesn't mean that's all there is to it. Because that G, again, if you go back here, this vessel here is located distal to all of that. So essentially, the anastomosis is like this. However, the anterior spinal, if there's an anterior spinal coming from here, well, there is still a segment, there is still a small segmental artery that's limited to the supply of the vertebral body and the dorsal division here. And so that's the idea. So here's a left T9 injection, and the left T9 injection, indeed, you see the anterior spinal originating from here, as well as the blush of some of the blush of the vertebral body. So some of these like variants have some implications occasionally. The median sacral artery, very important artery because that allows us to see the sacrum and other segments of the sacrum, the lateral sacral arteries on the side, which are homologs of the pre-transverse anastomosis. So again, that's the idea. And here is a companion case. Now Lucas left because he had to do a case, but here is another importance of injecting something like that. Here you see again, so here's a dural fistula, right? So here's a vein, here's an artery that's probably looks like an S1 supply, and then there's some lower supply again coming to this. So the dural fistula happens to be here. We always talk about that. You got to inject all the vessels if you're looking for one. Just some other examples. So here's a little bit of like this other on the cranial end of the of things. There's a lot of homologies and anastomoses related to the vertebral axis. You have here an injection of the left subclavian artery. Here's what we might call the vertebral artery, except it seems to be potentially originating distal to the thyrocervical trunk or at the thyrocervical trunk. Why? Because that is, in fact, not quote unquote the vertebral artery. One might view it as a thyrocervical, as an anterior cervical artery reconstituting the vertebral axis, and that's why the entry here is a little bit higher. And so the homology is that, in fact, like when it's like this, when the entry is a little bit above the C6 foramen, that is not, that is considered maybe a reconstitution by the thyrocervical branch. Here's an even better example. This is one of our former fellows, young Carl, sent us this beautiful picture. So here's a radial approach. You're injecting these vessels, you see some kind of duplication right here. Now, when you look at the lateral, the interesting thing is that neither of them is in fact the vertebral artery, neither this one nor that one. Both of these are actually anterior cervical arteries, and both of them are reconstituting what would be the vertebral artery proper at C4, it's a C5 nerve root. And so that's another idea of this kind of homology. Same thing here. Sometimes you see something like this. You have an injection from the subclavian, and then you're refluxing into a direct origin vertebral artery contribution. So another sort of duplication. Another origin, that's an important thing to keep in mind. So we're looking for the right vertebral artery. We inject the right brachiocephalic. Doesn't look like it's there. Thyrocervical. Where is it? Now we have a left vert injection. So again, we see reflux. We know that it's somewhere, but doesn't seem to be coming from the subclavian system usually. So when that happens, we have to look at the thoracic aorta. So this is a supreme, what we believe is a supreme intercostal origin of the vertebral artery, which is again homologous. So you look at this picture, kind of understand how that happens. And that can be important, of course, because sometimes there's a lesion on this vessel that we need to address. I think we can skip over that. So essentially, this is again like segmental organization, the balance of supply of the spinal tissues, of the posterior cervical tissues between the vert and the deep cervical artery. So here's a very vert dominant situation right here. The corresponding deep cervical is small. This is another anastomosis, a well-known anastomosis with the occipital artery, one of these quote-unquote potentially dangerous ones. If you're in the proximal occipital artery, you always got to watch out for connections to the vert. And so that's right here, there's a muscular artery, the C1 muscular branch, anastomosing with the occipital vessel. The extreme of that anastomosis, like this, would be a proatlantal artery. So the proatlantal artery is just the persistence of this connection between the occipital, or one of the types of proatlantal, and the vertebral axis, like this. So here's a case that kind of illustrates that. We have a vertebral fistula, essentially a transection of the vert, somewhere like at around C2 or C3, I guess. And so there's a high flow shunt here from the vert to the vertebral venous plexus. And you see an occipital artery coming as an external injection, the occipital artery, the muscular anastomosis, and then backfilling the vert because of the high flow demand. So there's a reversal of flow here, and this vert is supplying, is running into the shunt. Now what happens then? We close the shunt, so there's a sacrifice. You close this vert, but guess what? The flow reverses, right? And now you see the occipital artery resupplying the vertebral axis. So essentially what we've done is we've made a proatlantal artery, or the body has made it and we just kept it for that. And so, yes, we've sacrificed the vert, but there's still another, you've kept a robust connection between something and that vert is essentially functionally, the person has two vertebrals as far as the head is concerned. Omar and Tibor sent me this picture a while ago. It's a beautiful case actually of a PCOM. They did it like one of these PCOM basilar thrombectomies through the PCOM. But leading up to that is this picture of a person who has these verts, except obviously they don't look like verts exactly. So this is an MRA, and these are deep cervical arteries reconstituting the vertebral higher up. That's another case, Erez's case. He has some lateral pictures. So here's a lateral projection on the bottom. You see how that works. So there's a lot of different, some of it has some clinical implications, like for example, somebody has a vertebral ostium stenosis, right? So it's one of these lesions that occasionally we're asked to evaluate. Should we stent? What should we do with a vertebral ostium stenosis? Now, if you're going to answer that question, you need to do like a good imaging evaluation, understand like, does that person, like what's the hemodynamic? Is that an artery to artery embolus is one situation where that happens. Is there a hemodynamic need for this vert? Or there are other things that can reconstitute that. That's another acute case. We're asked to evaluate the status of a vertebral artery in a patient that got this post-op CT, except, look, just happens to be some people, just a fortunate situation. There's no vert in that foramen, and that happens. Like we're always told, like one of the dictum is there's no foramen without contents. Like if the foramen is a sizable foramen, well, it should have like a fairly sizable vertebral artery. It's not always the case. You can have a decent sized foramen with no vessel in it, or a vert in it in this particular case. And so that's just another person with a variance applied to the vertebral axis. No harm done. Okay, so moving on to the dorsal division, which is basically the stuff that goes into the spinal canal. Again, like outside in. So let's look at the epidural arcade, or there's different names. It has a different, we could call it different anastomoses. So the nomenclature varies, but essentially you see this diamond-shaped network. That's a continuous network up and down that corresponds to these pink vessels over here. And that's the principal left to right anastomosis, or right to left anastomosis. Between levels is within the spinal canal at the from this arcade. Sometimes, like, you know, if you have a young person, particularly younger people, like you could have like a ridiculous anastomotic injection like that. And you can see from this level that you're pacifying up and down a bunch of neighboring things, including right here through this epidural arcade, you see the radiculomedullary artery, and here's your anterior spinal, right? And again, so like this is one of those things. There's a lot of it is about technique. So we don't talk too much about technique, but spinal technique is paramount. We a little bit touched on that with Lucas's cases. Most of us do it under general anesthesia. There's a lot of tricks you could use. You could paralyze the bowel with a little bit of glucagon. That'll give you like half an hour of that. Paralysis, more or less, if you need to do that. General anesthesia, pharmacologic paralysis, apnea, all of these things that lead to acquiring good spinal images. You would try to center everything at the midline because the anterior spinal artery is going to be midline in most cases, unless it's displaced by something. And so again, just some examples, you see like lots of radiculomedullary contributors to the anterior spinal axis here at the vertebral level. Here mostly this is an illustration of the homology between the epidural arcade and the odontoid arcade. So odontoid arcade, this purple vessel here, I'm sure you're familiar with that. There's nothing particularly special about it. It's just the odontoid. The dens is that's a variant, osseous variant, and it leads to a vascular variation, but that's basically just another epidural arcade vessel, just having the shape of a dens. And that's connected to another important vessel, which is the ascending pharyngeal artery. And so if you go up here on this image, you see the homology between the ascending pharyngeal. So here's the odontoid arcade, and then you have the clival arcade related to the ascending pharyngeal artery and the meningohypophyseal trunk. So that's the continuation of that. And so you can think of that as like another system. And so, you know, that also has implications. So here's a case of Dr. Nelson's, you see something that looks like that. Well, okay, so what happens? Make a long story short, this is a foramen, this is a hypoglossal kind of level fistula, but it's supplied by the ascending pharyngeal artery through this connection. And you see whatever, they can generate a whole bunch of good pictures like that. And you see the tremendous congestion that results from this particular fistula. Okay, so moving on in terms of moving into the intradural space as far as the branches. So again, like mostly angiographically, we can see the intrinsic vasculature of the cord is often below the resolution of our angio images, but you can see the surface vessels, which of course the anterior spinal of which is the main one. This is just a sequence of an injection of the anterior spinal artery, of the artery of Adamkiewicz, giving rise to this anterior spinal. We see very well, we see the conus in the middle picture. the conus, these vessels called the rami cruciantes, or whatever we want to call them, which are basically anastomoses at the bottom of the cord, with the posterior spinal arteries, which are usually discernible at the level of the conus. And so you see those right here. And very importantly, I think quite importantly as far as technique, when we inject a big anterior spinal contributor, we should be able to visualize in the venous phase the veins of the cord. And that usually there's like one radicular vein that drains it, or sometimes there's like some other vein that goes down there, or the filum terminale vein. But essentially you want to see the veins. If you don't see the veins, you have, I mean, with experience, if you felt that you've injected a big enough artery, but you don't see the veins, something is wrong. Like there's some kind of venous congestion state present, and that has to be accounted for. Particularly if you're looking for like a fistula or some other issue. A venous phase, a normal venous phase, is reassuring that the venous that the venous congestion situation is under control. Of course, that's all very qualitative. There's not aware of any quantitative ways of addressing that in the cord level at this point, but something that certainly would be useful. Occasionally, so here's just a cone down view of this. Again, it's a young person with angiogram. And occasionally you will see the sulcocommissural arteries, which are basically arteries that are going into within the ventral sulcus of the cord. And you see them as andon arteries. You see these dots, and they're going to go into the sulcus, and they're going to supply the central portions, the gray matter of the cord. And then again, you can see here the connections to the posterior the spinal arteries, and then again, the venous phase. You want to see veins in the venous phase. Okay, so again, like just a little bit of elaboration on that. Again, young person, here's another variant, so duplicated. Here's that vert connection again. Young person, lots of anastomoses. I think this whole idea of like embryonic, the embryology we reviewed with multiple suppliers, then like kind of coalescing into a more limited number of radiculomedullary arteries. I'm not really sure, but it seems like that continues to some extent postnatally, because very often we see in children something like this, which is a rich network, and that's not so commonly seen at the adult phase. And I don't think it's just related to the pressures or the hemodynamics of the injection. I think probably there's some maturation that happens there as well. So anyway, so here's another set of verts, typical like vertebrobasilar junction, anterior spinal origin. Here's another one from mid-cervical segment. And even in this picture, so this is like not a very, it's not a very impressive anterior spinal axis here. But if we do a dyna CT, we can identify, if you look at this segment, you can see some of these sulcocommissural arteries here on the dyna CT. I'm pretty sure they're not veins. But that sometimes is a question if you're doing it like a 20-second dyna. But these are arteries. And so the resolution of the dynas, again, is like a whole other universe over there that we're going to touch upon in a second. Just whatever, some variations. Sometimes you can see something as crazy as this. Sometimes, and so here is a nice posterior spinal network here, a lateral spinal. We're not going to get into the lateral spinal business at the moment. I think we'll save that for when we do the brainstem. The cervical, just one thing to keep in mind is that when if we're asked to look for an anterior spinal artery, we try and we believe that we should always be able to map it out in the thoracic and the upper lumbar segment. In the cervical spine, things are a little bit different. Up to 30%, I think, of cervical angiograms, including verts and all kinds of deep and anterior cervical arteries, will not identify a distinct anterior spinal axis. That's just how the cervical vessels are. I think Lazorsis has studied that a while back. So not being able to identify an anterior spinal artery in the cervical angiogram, if you can't find one, it doesn't mean that it may not be very helpful. in the thoracic and the lumbar spine, you should be able to find one. If you haven't found one, if you need to find one, that's a problem. And so there's like variations in the cervical segment. So here's they don't have to be a one. Sometimes they're duplicated like that in a completely normal case. Sometimes they're like that because there's a hemodynamic reason for them. So here's a person she has bilateral upper vert dissections, and so part of the reconstitution of her pica is through the lateral spinal axis and the anterior spinal axis like this. Of course, everybody knows that the radiculomedullary arteries don't always come from the vert. They can come from deep cervical, from the thoracervical trunk just as well as the vert. And so that's something that's very basic, and we need to know that. So here's an example of that. The supreme intercostal, of course, just another vessel. Can also do that as well. So here's a posterior spinal artery. That's a radiculopeel vessel. So that's, again, just technique, making sure the spine process is centered. Here it's like a touch off center, actually, but you can still see that the radiculopeel vessel has this tight hairpin turn and is off midline. And so that's something that's important to appreciate. Here's another variation. So we have two nerves. There's a dorsal and ventral nerve root, right? And so typically the anterior spinal artery or the radiculomedullary one would be located on the ventral one. The peel one is on the dorsal one. And so sometimes you have both, right? So here's a radiculomedullar peel vessel like this. You see both coming from one level. This is, I think this is just to illustrate, again, there's like a lot of variation. Okay, this is a case that kind of illustrates some of these, some of the kind of like more advanced anatomy of the vessels, the intramedullary vessel or intradural vessels. And again, there's a lot of variation that happens in terms of how many anterior spinal or posterior spinals we can visualize. Sometimes there's just a few. Sometimes there's many. So here's a right T3. You have one here. Here's a right T5. You've got another one there in fairly close proximity. And this is already after some embolization of T6. So we'll come back to that. So here's a right T7. This is the same person. Just happens to have like lots of them also coming from the right, which is also unusual. More often than not, the origin is on the left. And then finally, she does have a kind of like classic, quote unquote, normal, a little bit high, left T9 radiculomedullary Adamkiewicz vessel. Now, this is an interesting, like one of these illustrations, we get into a little bit more of like fine, like order anatomy. So here's a person, she has a hemangioma located where you can see where. And so you can imagine what the supply to that lesion would be from a diagram like this. And indeed, like we inject the right, this is the right T5. So the image I'm pointing to is the right T5. That's the same picture I showed earlier. So here's the radiculomedullary artery. See the anterior spinal axis. The right T6, that's the hemangioma, not particularly too vascular, but you can see how it has that hemangiomatous look. And here's the right T7, again, the anterior spinal here. The Dyna CT confirms what we would think is the supply. So the supply to this lesion comes from some of these little short vessels coming from the relatively proximal segmental artery. And then the dorsal division right here coming through the neural foramen, and that contributes prominently to the supply of the back part of the hemangioma. This is the coronal reconstructions. And the coronal reconstructions, you see kind of like what becomes important a little bit later. You see this network. This is a dural branch. So most of the dural branches we focused on is the epidural arcade, which on this picture is this kind of like right to left, left to right connection. But there is also this called the Lesjanius Bernstein Terbouje is assigned it a name of like an ascending and descending dural branch, kind of in the lateral space. So I think another way to think of it is a lateral dural branch, because ascending and descending depends which level you're injecting, but it's kind of a, obviously it's a column. It's one of these longitudinal anastomoses. And so here you're injecting the right T6. You see this connection here, and the connection is to the right T5. Now, obviously that has importance because where this arrow is, you're going to have the radiculomedullary artery. And so, and also this would be the reconstitution. If we were to block the right T6, then the hemangioma would be reconstituted through what they would call the descending limb of the right T5 injection. And so sure enough, so here we have a stereo pair. If you're like, we're recording this, but if you have time later, cross your eyes. It's really beautiful. You see this in 3D. And in 3D, you see it. So here is that lateral dural branch, I guess I'll call that, and that's the connection. And here you start to see a little bit of that radiculomedullary artery. And indeed, if you go back here from this right T6 dyna injection, you see a ghost of that here, so you got to watch out. So anyway, we keep going. Typically, when we embolize these, what we do is we just put some coils a little bit distally to block off the runoff of particles, which we like to use particles typically in this. So whatever, we put the coils here, then you drop back proximally. And then from this proximal position, mostly the stuff is going to go into where you need it to go. So you see the blush of the hemangioma. And from here, small particles, that's the PVA, so that's 45, 150 contour particles is what we like to use. And in the end, basically sometimes we would put a coil here. We didn't put a coil here for some specific reasons and related to this case, but what you see here is after the embolization of T6, predictably, as you can imagine, if we go to T5, so okay, so radiculomedullary is still intact, anterior spinal still okay, but you see a little bit of that blush of the hemangioma from, again, that from that lateral dural network. And so here you see the dyna CT of the T5. From the T5 injection, these images, the coronal reconstructions of T5, you see that there's a descending limb, so this white arrow points to the stump of that same branch that we had embolized from T6. Now you see from T5 the reconstitution of the hemangioma, and you see also, of course, the spinal cord right here. So here's right T5, right T6 side by side. There's the injection. Now you see, like, you start to see a little bit even more. So again, like if you look at this picture, for example, so here's that descending limb. So here's the principal supply of the hemangioma is from this lateral dural branch. Also present is the radiculomedullary branch here. That's on the dorsal, that's sitting on the ventral nerve root branch. And then there is yet another branch here, which is related to the epidural arcade that's supplying the back of the vertebral body. And so now you start to see that, like, if you're looking at this, well, we don't really have to embolize this necessarily, but if you wanted to, what you could do is you would have to subselectively catheterize this branch here and do a subselective embolization. This is a stereo pair of the same injection, so you could look at that. And here's the subselective catheterization. So this is, I think, a headway duo sitting in this position, and then you see the three branches. So here's the radiculomedullary contribution via the ventral, the radiculomedullary branch on the ventral nerve root. This is the branch that goes into the epidural space and that supplies the back of the vertebral body. That's the lateral dural branch, and that's the hemangioma. And so here's the, again, like just a little bit deeper, microcatheter subselectively here. Here's the blush. That's the blush, that's where the particles go, right? And now you see this. So this is during embolization. You start to see some reflux into that epidural branch here. That's the black arrow, same branch as this. And that's the signal that it's time to end, because it's reflexing here, the next one is going to be that one. And so we end here, put a little coil in. At the end, you see the anterior spinal is intact. And you see how there's some contrastasis now in the hemangioma because now you've really filled it up. So just a demonstration, it's an anatomical demonstration. You may or may not, the question is, do you have to do this? Can you just why can't we just resect it anyway? You probably can. I'm not saying that this is critical, but I think it is safe. Occasionally you might find yourself in a situation where you really do need to do this. Okay, so I think we're, okay, it's 9:42. We have a couple of cases to show of similar kind of ideas. Maybe I should show that. At least one case. Let me show this case here because I think it illustrates the same point. Let's see. All right, so I think you're seeing, I think some of you might have seen this case. It's a dural fistula, typical MRI of a dural fistula. A little bit, we can get into some fine details of this MR. There's some interesting T2 space issues there that we can discuss. And so here's an example of a dural fistula injection. Now again, you see the vein. So here's the fistula is here. Here's the draining vein, and that's the anterior spinal axis here. So not sometimes you find that the fistula and the anterior spinal arise from the same level. Essentially, these are surgical cases. We send them all to surgery, and they do very well. Here's a stereo of that. Now, occasionally, you can get to appreciate something a little bit different. And so, again, this is like just a fistula runoff. So we like to do that. You do a delayed runoff, and you can kind of see some venous congestion here. Now, in this particular case, so there's a unique situation. And what you find is that if you look at it very closely, we kind of did this, we did a dyna, and you discover that, looks like the radiculomedullary supply from this branch, which is the ventral, the branch of the ventral nerve root, is different from the supply to the fistula, which seems to be coming from this vessel, which is the dorsal nerve root. And so the anatomical variation that we have is this. So here's a stereo of that. So the more you look, the more you realize that they're actually separate, and there is a good amount of safety. So if you were to park your catheter here, in fact, it would allow a reasonably safe, I think, embolization of the fistula from this position here, because they're coming from, they're located on separate nerve roots. So we have dyna CTs to show that. And essentially, this is the variation. So the schematic of the variation is right here, separate vessels, separate nerve roots. And so ultimately, you could get in here subselectively, pick the right one. You see the fistula, and you shoot some glue in there like that. And that's the post. So again, doesn't happen too often, but if you essentially a lot of it is technique, is just paying attention, meticulous technique, and the dynas are very useful. We do more and more of those in the spine. You can achieve a good dyna, and that can give you a lot of useful information sometimes. Okay. Now, why don't we? Let me stop now. Probably we have a lot of. In the interest of time, I think we're going to show. Kitty Pong has some cases that illustrate the importance of this stuff here. We didn't get to the veins. I think we should probably have a separate session on spinal dural fistulas and spinal venous anatomy, because as Lucas shows, the veins are supremely important. Spinal dural fistula is a venous disease. It's a venous congestion disease. Most of the stuff that happens with the fistula, the the anatomy, the pathophysiology, the clinical presentation. It's all about the veins. It has basically nothing to do with the arteries. And the same as he showed, like sometimes even the intramedullary lesions, high flow AVMs, the modes of presentation, yes, they hemorrhage. We know they hemorrhage, but it's not always the hemorrhage. Sometimes there's a venous congestive state that actually drives the clinical scenario, and that drives your treatment. The idea of the treatment is to reduce the venous congestion. Okay, I know it's been a lot, so thanks for your attention. One of the questions is, what is the setting you use for DynaCT? So it depends on your machine. We got the Siemens. So it's a 20-second Dyna. We inject, basically, it depends what you want. You can inject from the guide, I think like a 1.5 or 2 cc per second injection, if you're in a good guide position, is fine. And you could use, like we use 80, 100%, like we use undiluted contrast a lot, because so a lot of people use diluted contrast in the Dynas because why? Because they put in a pipe or something there, and you want to be able to differentiate between the vessel and the metal of the implant. Here, there's no implant, at least not yet, and so we are basically, you want to use a more concentrated injection so that the contrast is denser, the vessels are denser than the bone, or the ounce field units are denser, higher than in the bone, and that allows you to like do some cool recons. I think you get good, it's either like that, or if you have a microcatheter in some position, you can use a microcatheter injection. Typically for that, we don't use an injector. You just stay in the room, you fill your syringe and put some shields up and just inject it yourself. Frederick is asking, do we use 4D DSA? For some reason, we probably should use it more. We don't, as a rule, or as a whatever, we haven't, but maybe you can comment if you have anything that you think of.
Only problem with 4D DSA is the spin is a little bit longer, but because you don't have contrast at the beginning and you have washout at the end, your spatial resolution of the anatomy is not quite as good as with like a traditional standard 6-second DSA. But the spin itself, there are two versions. There's a 6-second 4D DSA spin and there's the 12-second DSA. But at the very beginning of the injection, you're not filling you don't have contrast in the vessel. So you don't get as much resolution of the vessel. So if that's what you really want, anatomical resolution, it's not as good as standard 6-second spins.
Yeah, I think it depends. Yeah, definitely. So one question is like if you're trying to get dynamic information from it, right? So like you would want to differentiate the venous phase, and if it's too long, like everything ends up being mixed.
For shunting lesions, or also for sometimes for flow limiting stenosis, it's useful, but definitely for dural fistulas or for AVMs, it's useful. But if you're going to do it just to isolate the anatomy, I don't think the resolution is not quite as good.
Yeah, I agree. I don't think it's for anatomy. Like if you're looking at, say you have a spinal AVM, maybe you want to see how that's going. We haven't used it. The 20-second, I like the 20-second Dyna because the resolution is incredible. Yes, like it takes some juice to accomplish that. But sometimes, like you're saying, if you want spatial resolution, you gotta invest into it, and the investment is dose. Okay, anything else? Kitty Pong.
Yeah.
Okay.
Okay, maybe I can take it from here.
Yeah, thank you.
Okay, thanks, Max, for the lecture. It's I'm gonna take you through another aspect. It's not really, pure anatomy, but something that people should know to do the right diagnosis. So this is not. This is just to summarize. Max talked maybe because you can see a lot of things in here, and it's a stereo pair. They say that like a picture is worth 1,000 words. Maybe this one is worth like 2,000 words. Huh? It's 2 pictures. It's a very beautiful pair here, You can see the anterior spinal artery axis here, the anterospinal artery, radiculomedullary artery. One level below, you can see the radiculopial artery here. So this is a dural shunt over here. You can see all the anastomosis, the vertical ones, the horizontal ones over here, not very obvious over here. So there are like connections up and above, left and right. Okay, just to give you the whole picture of what Max was talking about. So I'm going to take you through another aspect of this thing. So this is an injection of the, again, you can see two levels with one injection at the left TH12 and L1. And in this case, it's quite obvious that you have a shunt over here. And all you see around here, it's obviously the dilated veins. So you can see instantly that this is a dural shunt. Okay, so typically you can see the edema in the cord and some dilatation of the veins. You can see as flow voids on the MR. And usually people, the patients would be like male, a little bit higher age, and with slow progressive myelopathy. Okay, you probably know this very well enough, but I'll take you to another aspect of this. So every time you see an edema in the cord and with flow voids, the first thing you should expect to have is like a spinal dural AV shunt, unless proven otherwise, or even though it's proven otherwise, sometimes you shouldn't trust the people who said it's not dural fistula. Okay, why is that? So sometimes we can have cases like this one doesn't have. Okay, so if you have something that you must rule out spinal dural AV shunts. But we can have cases like this. Okay, so this one, she was a lady, 63 years old. She was diagnosed as myelitis for 1 year before she came to see us, and she became totally paraplegic after like 8 months before she came to us. So this is like edema in the cord. We don't see any flow voids. It's not very typical for this. Angio showed something like this. It was done in our hospital. It doesn't look like very dilated veins, some small veins and stuff. So what's going on over here? So I'm going to show you. So this is the non-subtracted image of this injection, the same injection. You see the same, it might look to some view like an artery. Maybe it looks like a vein for some of you. And in the late, I think I can advance through the, like very slow. So this is the frame by frame picture of this exact structure. It has some kind of like a hairpin curve over here. The upper limb is here, a little bit like, multiple corkscrew appearance. So maybe some people will think this is a vein, arteries. So this is a very, very late phase of the same injection. You see all the, we believe this is a vein and it's all congested. It doesn't have any way to exit from the canal. So that was the cause of the congestion. So let's look at the same patient again. So this is the picture I've just shown you. It might look something like this. Some people might get confused with an anterospinal artery itself. But on the right here, I put another picture of, I don't remember what level it was, but somewhere around the lumbar level, you can see another similar vessel having the same type of, hairpin curve. And actually, we can put the bone back like that. You can see it's at the midline over here. And the same thing here. Both are at the midline of different. So this one is a little bit higher. One level higher is here. You can see the position in comparison to the bone. So this one is a little bit one level lower, similar shape. So do we have two anterospinal arteries? No, actually, the left one is the vein. So we have a dural shunt at this level. even though it looks a little bit like a hairpin curve, typical with the anterospinal artery, and it's not very dilated. So why is that? We will probably go through the anatomy of the veins, as Maximus said, but just to give you the idea of how this thing can be explained by anatomy. So this is the ventral side of the spinal cord, actually upper cervical spinal cord. You can see the veins here, which are called anterospinal veins, are like embedded a little bit deeper inside the pia matter of the spinal cord. And in contrast to that, you can see the posterior spinal veins are a little bit more dilated. At the surface, more superficial than the ones located ventrally. So what does it mean clinically? How does it give the clinical impact? So if you have lesions that go mainly into the anterospinal cord system, anterospinal venous system, it's usually you don't get a lot of dilated veins. You can see something like this, but you have something at the posterior side on the dorsal side of the spinal cord, you can get very massive dilated veins on your MRs. So it's more easy to make diagnosis on the, when you have the veins dilated. So this one, the patient came very late. We treated the patient. We got the glue inside the canal, and but unfortunately, the patient didn't have any improvements. So the message from this case, this kind of shunts can present without flow voids on MR. So even though you have, you don't have any flow voids, still, it's not. You cannot exclude the possibility of having a dural AV shunt from your diagnosis. So this is why. So the anterospinal vein is the cause of not enough dilated veins that you cannot pick up on your MR. Okay, so there's a report from the group of Dr. Bernstein, also from New York, very long time ago, about 20 years ago. They collected these cases. They had 8 cases in their series of 80 cases of spinal dural AV shunts. And the one on the left, so this is the case number 1 in their series. You can see, again, this is anterospinal vein. In contrast to that, this is anterospinal artery in this case. They have the hairpin curve, but a little bit different, okay? So another case is one looks a little bit more like an anterospinal artery, but still, this is not actually the artery, it is the vein. There's a shunt over here. It might feel scary to embolize from somewhere like this if it's you think it's a vein, but if it's actually an artery, you'll make a very big mess out of this case. So this is actually the real anterospinal artery. So the last one they showed in this paper. So this is the last another one, and again a hairpin curve. They didn't show the anterospinal artery in this certain case. So so this is something you need to be aware of when you make diagnosis in this kind of cases. So that's one story. That's another story that I would like to share. 2 more cases, short cases. So this is quite typical. You can see the edema in the cord, 24, male, progressive myelopathy. In this one single slide, you can tell this patient probably has a dural shunt somewhere in his spinal cord, but you cannot tell where from this image, okay? So that's a problem. You cannot tell where in this image. That's the problem. In the previous center, they went in to do spinal angiogram. Probably they try to cover everything they could imagine. But unfortunately, they missed something out. There are more pictures. So thoracic, lumbar, some of the injections are not very nice. You could see like this one or this one, they just made the injection through the aorta and felt like satisfied with the pictures, which is not very sufficient for cases like this. So we did the same thing. The patient came to us and we did the same thing. So this is anterospinal artery. Again, this is the real anterospinal artery, the hairpin curve. We went down to the lumbar level, very low. At this level, we tried to inject into the lateral sacral artery, but we were still in the common iliac artery over here. And that injection, we saw something that shouldn't have been there. So this is the vein. So the only thing that we needed to do, just advance the catheter a little bit more distally into the lateral sacral artery. This is like, oblique view or something. And you can see a branch coming here, forming a shunt at this level. So this is the microinjection again, and glue. And this just treated the lesion. Just to show you again, the artery is coming out from this lateral sacral artery, looping here. Probably the same type of artery we saw in Lucas's case, but that one went up to the conus. This just just stopped at the dura and becoming the feeder of this shunt. That drains into the intradural vein. So this is the first hospital just missed they didn't go selectively in all the vessels that can go to become a feeder of this kind of shunt. Okay, similar story, different, a little bit different story, but similar. 66 male, again, reported as angio negative for dural AV shunt. The previous academic center, they did 2 sessions of this spinal angio. Again, edema, flow voids. Not very nice, not very selective injection. Again, they searched from head to toe, but they couldn't find anything. So they did this twice, and they said this patient probably doesn't have a dural shunt. It's probably something else. And sometimes he got somehow he got referred to us, and so this is the answer to this case. We did a selective injection at L4 on the left side, and we see something like this. But looking back at the angiogram done in previous hospital, so this is an injection very close to what we achieved in the diagnosis. So again, non-selective injection. But if you look carefully through the late venous phase, you can see something that's not supposed to be there. The vein is very faintly over here and very faintly over here. So similar thing in our place. So a little bit, if you are a little bit more selective, what would happen? You can get something like this. You don't see any contrast in the aorta. So it's quite selective enough to push the contrast into a very slow flow lesion. This is like epidural shunt. It's not really a dural shunt at the sacral level. So again, it's very slow. If you stop injecting, if you don't have a prolonged injection time or anything, you might miss, or if you are like non-selective, you won't have enough volume of contrast to be able to feel until the end of injection into the vein, because it's going to be very slow. So this kind of very slow flow lesions that you can sometimes miss on even something that is considered to be a thorough spinal angiogram. So again, just went in, embolized this, put glue inside. So this is curative for the thing. So I would summarize with this interesting report from the group in Johns Hopkins, AGNR 2017. They did spinal angiogram in 30 patients previously reported as normal in other institute, and they subsequently found 18 patients with shunts, epidural shunts in 9, 8 in dural shunts, and and 2 perimedullary shunts. So more than half the patients that were supposed to be angionegative in other hospital were have subsequently shown to have this kind of shunts. So what were the problems? So sometimes it's actually there on the angio, but they just couldn't pick it up. So it's about 50% of cases like that. And some of the cases not documented at all. It wasn't shown on the angio at all. Why is that? In all instances, it's very interesting to know about this because it's in our own experience too. All the cases are like very low in the lumbar level. All the cases that were missed, like they were below L3 in all cases. And sometimes they went very close, like I've shown you in the last case, but the injection was like not really adequate for the lesion. So to get a complete angiogram, you have to think about the sources of spinal cord arteries. As Maximus has shown you, they can be, they can share the left and the right. So these are like the area of the neck that you should inject. Here in the thoracic and the lumbar level, it's more very aligned like segments. It's quite a little bit easier to catch. And at the lower part, you have this kind of, sacral arteries that you have to go into. So you can summarize these kind of arteries as they can be they originally they were like segmental arteries, but sometimes they join like intersegmental arteries, like vertically. So you have in the neck area, you can call this area like intersegmental artery source, and the segmental artery sources at the thoracic and the lumbar level. And lower down, you can have the lateral sacral artery also, which is like the equivalent of what we have at the neck, like the intersegmental arteries. The medial sacral artery is like an extension of the aorta itself, so it cannot be said to be intersegmental artery. So you need to imagine this kind of sources that can give origins to the spinal cord arteries or even the dural branches to build to get a complete angiogram. Okay, so the message from these two cases. So the angiogram, the spinal cord angiogram, should be done selectively or super selectively, and we prefer to do the angiogram, spinal cord angiograms, through under general anesthesia to stop the motion of the patient completely. And also, if you cannot find the shunt and the situation is so obvious, you have to get complete spinal angiogram, which is not quite easy in some of the cases. So maybe this kind of cases should be, examined again in some experience centers. I don't know. So that's it. Thank you, Max.
Thank you, Kitty Pong. Thank you. Yeah, some beautiful cases. And it's interesting, I think, in the big picture from Philippe's article, that it really is like more like a 50-50. So a lot of what we emphasize is the technique, right? Like making sure it's GA and this, that, and the other. But importantly, like underemphasized is interpretation. So in half the cases, it's just like understanding what you're looking at, essentially. And that can be difficult, like what you've shown. Sometimes it's easy when it's easy, but sometimes it's not. And it goes both ways, because like I've been contacted by several patients of other, people would write me email and say, I went in for an angiogram, they did something, and now I'm like in a wheelchair and this and that, and the real stories. Obviously, there's nothing to be done about, what happened, technically speaking, but it has tremendous implications. Anyway, we'll have another session on spine, because we really didn't get into like the epidural thing you showed is beautiful. Like there's just so much more stuff in there that we need to really flesh out. So we'll maybe plan on doing that either next month or the months after, sometime close by. Okay, any questions to Kitty Pong or to anyone, any comments? Okay, again, thank you, everyone. Giripong, thank you for showing your things. Thanks for coming, everybody. We'll adjourn here. So the next one will be whatever is the first Tuesday of October. And we'll go ahead, we'll pick a topic in the next week or so. And we hope to see you back. This will be recorded, or this is recorded. So we will, I think we'll probably make it available online. We'll check back with that. Thank you and goodbye.